Alrighty, I think we'll get going here for the day then. So again, welcome to today's special series, Project Echo Clinic, where we're going to be talking about CRE in Nevada. We'll start off with introductions just of our speakers and our hub team for the day. There's a lot of folks signed on, and I think introductions would probably take us about half the session, so I don't want to waste that much time. So we'll just do introductions of who you'll be hearing from today. So hi, I'm Troy Jorgensen. I am the program manager for Project Echo Nevada. If you're not familiar with Project Echo, we are a program where we put together teams of specialists, multidisciplinary teams of specialists that we have here in the area and through the university. And we do sessions like this one today where we connect with providers, healthcare administrators, community health workers, and train them on current best practices and give them an opportunity to present their patient cases and receive some free consultation on those. We're really aimed at the rural and underserved areas of the state where there's not as easy access to specialists and that knowledge and interaction. So that's a little bit about Project Echo and what we do. And I'll share a little bit more later about our antibiotic stewardship echo clinics that we hold on a monthly basis. So I'll move on here. And Vicki, do you want to start us off?
Hi, good morning. I'm Vicki Kohler, and I am a Quality Improvement Advisor for Coimagine Health, and I also sit with many of the 15 members on the Nevada ASP program board.
Thanks, Vicki. Cece, are you on? Do we have audio for you?
Yes, I am here. Can you hear me?
Yep, go ahead.
Okay, perfect. Okay, thank you. Thank you, Troy, and thank you, Vicki. And hello, everyone. Thank you for joining us. First, I would like to share the SNHD Antibiogram data. Are we doing introductions first? Or
yeah, we're just going to run through introductions and then we'll get into the presentation.
Oh, okay. I'm sorry. Okay, yeah. So this is Chidima Njoko. I go by CC, and I'm the Health Facilities Inspector and Antibiotic Resistance Coordinator for the state of Nevada.
Thanks, Cece. Then Ashley. Oh, go ahead. Oh, sorry. Go ahead, Ashley.
Hi, I'm Ashley Fosdick. I'm with the HAI team of OFI at the Division of Public and Behavioral Health, and I have a background as an epidemiologist. I'm a health facilities inspector.
Thanks, Ashley. And then Dr. Epstein, go ahead.
Yeah, can you hear me?
Yep.
Okay. Hi, I'm Lauren Epstein. I am on the antimicrobial resistance team at CDC, and I'm an infectious disease doctor by training. And I'm really excited to talk to everyone today. Thanks.
Thanks so much. It's a pleasure to have you. And then Alan, go ahead.
Hi, I'm Alan Fisk. I'm in the Elko office, and I'm here for technical support. If you have any technical issues, please let Troy or myself know, and maybe we can help you.
Thanks, Alan.
Thank you.
So yeah, we've got a big group today, so I don't want to spend time going around and having you all introduce yourselves. So I sent something out through the chat. You'll see it as kind of a little orange bubble that pops up at the bottom of the Zoom window. So if you wouldn't mind just writing in your name, your credential, your location, that sort of information for us to know who you are, who we're speaking with today, that would be greatly appreciated. So we'll start with the presentation from Cece today. So Cece and Ashley. So I'll take you both off mute and pull up those slides for us.
Okay.
So can everybody see those slides now? Okay. So Cece, go ahead. And when you want me to advance to the next slide, just let me know, and I'll click to that for you.
Okay. Thank you, Troy. Hello, everyone. Thank you for joining us. The first thing I want to go over is our CRE update, so the number of cases that we've been seeing in Nevada. Okay, you can go ahead. Okay, and so the first thing I'm sharing is the SNHD Antibiogram data. I was working with Duane with SNHD, and she did an analysis on the 2016 Antibiogram data regarding CRE and other CROs, such as the Enterobacteriaceae and Proteus 2 years ago. And at this time, she got an astonishing number of 2,000 plus cases for the year. And she focused on CRE in acute care hospitals and only included Enterobacter, E. coli, Klebsiella, and so all the CREs. And when she did that for 2017, she got an estimate of 257 to 690 cases. And then when this was repeated in 2018, she got 136 to 480 cases. And also, this is also keeping in mind that this does not include the HCA hospitals and nursing homes. And the way that she calculated it with the lows and the high numbers is she got a total of the number of isolates for the year and the number of isolates among them that are resistant to the carbapenems. And so she got a low and a high percentage of 0.8 in 2017 and 1.2% and 1.2% high, and then she multiplied this number by the total number of isolates. And the number of isolates in 2017 was 32,172 isolates, and in 2018 there were 13,357 isolates. And we're unsure why the number was low for 2018, but it's something to consider when you're looking at the data.
Who gave you this data?
This was when with SNHD.
That's a lot lower than she said at the last Nevada ASP meeting.
Yes, and that's because the 2,000 number that she mentioned was looking at the 2016 data, and that's when she was looking at CRE and CRO. So when she was looking at just the CRE, that's the numbers that she got for 2017 and 2018.
Thank you.
Okay. Thank you. Okay, next slide. Oh, we're already on the next slide. Okay. So for the case counts that we got from the reports that we've been receiving from healthcare facilities throughout the state, we got a report of 410 unique cases, and that's after we filtered out from the 670 reported cases that we got. And from the 410 unique cases, we found 130 unique KPC cases, 7 NDM, and 1 KPC NDM, 1 KPC VIM, and 1 KPC OXA48. Okay. And next, Ashley will be discussing the current outbreak situation that we are facing. And we want to recognize want to point out that some receiving facilities do have a higher burden of CRE than other facilities, which we do put in consideration when we're assessing if there is an outbreak situation or not. Okay, so I'll be handing it over to Ashley.
All right, next slide. All right, so we've had 2 recent outbreaks in a couple of different facilities that I wanted to highlight. The first one is a VIM and KPC outbreak. So you probably are all familiar with the different carbapenmase enzymes. So the index case in this situation was on a ventilator in a rehab facility, and they had VIM and KPC detected in a rectal swab. They had been screened because a roommate had KPC. So this particular patient was a pretty severe case and had been in 5 different acute care hospitals in the preceding weeks to a little over a month. So CC and I actually went out and conducted assessments at all of those facilities. Now, OFI consulted with the CDC regarding the index case, and CDC provided many detailed recommendations. The 2 of them I want to highlight are they recommended that the facility implement enhanced barrier precautions on the entire vent unit. This is something that will be addressed later in this call. And they also recommended conducting enhanced environmental cleaning on every shift. So there are 3 shifts at the facility. They wanted that done every shift. And to date in that outbreak, there have been 9 CRE cases that have been identified from 41 residents who were screened. 7 of them were KPC, 1 VIM KPC, and 1 NDM KPC. So I think that's something that will also be addressed later in this call is when you see different carbapenamases detected in the same outbreak. So rescreening is ongoing for that outbreak. And the other one I want to highlight is an NDM KPC outbreak. in an acute care facility. So the index case here was on a ventilator also. They had NDM detected in a bronchial lavage specimen, and they had also been a patient in multiple facilities, including 3 acute care hospitals and a hospice before they expired. So a contact to that case had NDM detected in sputum, and 2 patients in that particular facility subsequently used the same ventilator. Fortunately, a non-conductive bacterial viral retentive filter had been used. These are commonly used, and so that prevented backflow. Another contact with KPC was detected from rectal swab. They also expired. And multiple facilities are screening contacts in the units or entire units, including patients who may have used the same equipment during procedures. And as of now, 3 NDM KPC, 4 NDM, and 2 KPC have been identified in that outbreak. And whole genome sequencing is in process at the Nevada State Public Health Laboratory. So one thing I want to highlight, you can move to the next slide, is that we'd like to use this opportunity to remind everyone, oh, that slide wasn't there, okay, to please report CRE and CP-CRE cases to OFI and to forward isolates to the state lab as soon as possible for further testing. In one of these outbreaks, one of the specimens was unfortunately destroyed, and so they were unable to perform whole genome sequencing. So if you can send those to the state lab as soon as possible, they can do additional testing and whole genome sequencing, and they'll save the isolates indefinitely, or for at least 2 years. Also, please remember to use the interfacility transfer form when you're transferring patients. And you're welcome to call us if you have any questions or you can't reach the receiving facility. You can also send us a fax or a secure email. And the slide that's missing is our fax number and our email address. I'll just mention and get that information. So our secure fax is 702-486-0490, and our email is dpbhhai@health.nv.gov. That's what I have. Thanks.
Thanks, Ashley. Yeah, so if you'd like to request those slides from today, you can contact us. You can contact us projectecho@med.unr.edu, and I'll send that email address out through the chat as well. So if you need the slides or anything else from today, just contact us at that. So with that, we'll turn it over to Dr. Epstein from the CDC, and I'll get your slides pulled up here and give you control so you can actually click through them at your own pace.
Okay.
All right, so on your computer, you can just click on the screen and then click one more time and it'll start advancing them for you.
Is it, did I do it wrong? What do I need to do?
Here, just a second. There you go. So yeah, just click on just on the slides anywhere and then you'll be able to have control. There you go. So go ahead.
Okay. Oh, great. Okay. Thank you. Got it. Sorry. So thanks again for having me. This is my standard no disclosures, and the findings and conclusions are mine and not necessarily represent the official position of CDC. So I'm going to talk today about containment strategy, the background for containment, and this was really initiated back in 2017. And I'm going to talk about the resources that are available through the Antibiotic Resistance Laboratory Network, and many of you may already be familiar with a lot of this, so it may be review. And I know a couple of questions have come up in relation to the outbreaks that you're working on, so I'll talk a little bit about enhanced barrier precautions, but also give a plug for a COCA call later this month, where they'll go in depth about enhanced barrier precautions. And I'm also going to talk about some of the questions that you raised in the outbreak and see if we can answer some of those. So, and I think at the end there'll be opportunities for questions, but if not, my email is in here too. So if anyone wants to reach out to me directly, please feel free. So I first wanted to start off with a slide just talking about the Division of Healthcare Quality Promotion, because I think people know CDC and sometimes don't know exactly who's helping with these different responses since it's a big organization. And the mission of DHQP is to protect patients, protect healthcare personnel, and promote safety, quality, and value in both national and international healthcare delivery systems. And this is just a snippet on the slide of many of the things that are done in the division. But in order to accomplish many of the things that we do, we work very closely with state and local health departments and many of these outbreak initiatives and containment. So it's really really important we have good partnerships with the states to really do a lot of that containment work. Carbapenem-resistant organisms, we know, are multi-drug resistant organisms, and they cause serious infections with high rates of mortality. But what we're particularly interested in from a public health perspective are these carbapenamase producing organisms. And these are enzymes that degrade carbapenem antibiotics found in mobile genetic elements, and they can be transferred among other gram-negative organisms. And we're particularly concerned about these because of their potential for rapid spread. So this is the classification. I'm sure you've all seen this before, but just highlighting the 5 carbapenamases that we're most concerned about that we can rapidly test for. So KPCs, NDM, IMP, VIM, and OXA48. And these are really the most common that we see that we track across the US right now. So we know that there's a potential for the rapid spread, rapid increase of carbapenemase. And I like this graph because it really illustrates examples that we've seen from other countries over a 3-year period. And so you can see each color represents a different region. So Greece, Israel, Cyprus, Italy, and Romania over a 3-year period. And you can see that there's a rapid increase in the proportion of gram-negative organisms that are resistant to carbapenems over that time in each of the countries. I think it's a nice illustration of how quickly these can disseminate. And unfortunately, as we know, in the US, we're no exception. And the first carbapenemase producing isolate that was identified in the US was carbapenem-resistant KPC Klebsiella pneumonia that was collected from a North Carolina hospital in 1996. And this first report was actually published in 2001. And since then, I think this slide is really striking because since then, we've actually identified it in all 50 states. And it's the most common carbapenemase that we see. But I think that it's important to note that while we see it in every state, it's not, the epidemiology within the state is not homogeneous. So in some states, we may see it almost endemic, and in other states, we see it rarely. So it really depends. And I'm going to talk about this later in terms of screening and why we may see it more commonly in other places. So, but we think with the other carbapenamases that they're still in early emergence, and we really think that it's important to respond so that they don't follow the same trajectory as KPC. In order, sorry, my slides are, I'm gonna go back a slide. There we go. In order to respond to the spread of the carbapenemase producing CRE, CDC developed a strategy of containment, and it was initiated back in 2017. And this is the systematic approach to slow the spread of novel or rare multi-drug resistant organisms or mechanisms through an aggressive response to at least one case of a targeted organism. And it focuses primarily on carbapenem-resistant Enterobacteriaceae and Pseudomonas aeruginosa, as well as Candida auris. And this containment strategy has generally been coordinated by public health with an emphasis on early detection and quick action. And I just want to put a plug on the right of the screen is the interim guidance for public health response to contain novel or targeted multi-drug resistant organisms. And this provides resources for health departments and healthcare facilities to initiate an investigation. And this is available on the CDC website. I'm trying to advance the slide, sorry.
Okay, sorry, yeah, sometimes I have to click off to read things in the chat. So just click it a couple times and it'll go.
Okay, sorry. So again, these are the tiers of what's contained in the public health response. And really how we approach a response depends on the tier. So tier 1 organisms we consider are the most critical. And these are organisms with novel resistant mechanisms in the United States, organisms for which there's no current treatment options exist, and they have the potential to spread more widely within a region. So for example, a pan-resistant organism would be categorized as tier 1. And tier 2 and 3 really vary based on the region. So tier 2 is defined as multi-drug resistant organisms that are not regularly detected in a region, although they might be more common in other areas of the United States. And tier 3 is defined as a multi-drug resistant organism that have been identified in a region before but aren't quite endemic. So for example, for KPC Klebsiella, it might not be uncommon in some states and would be treated as tier 3, while other cases may be rarely seen and would be treated as tier 2. So in different parts of the country, they may treat it differently depending on where you are. So I'm going to go through each of the steps of containment and what it entails. And this is an illustration of each of the steps. And depending on some of the tier, some of the components of each step might be slightly different. And this is all detailed in that response guide online. And I'll walk through each of the steps. So the first step of containment is rapid identification response. And this really relies on clinical cultures and the ability to detect resistance in clinical microbiology labs. First, healthcare facilities and health departments should be on alert for carbapenem-resistant organisms. I think that was mentioned before. So once carbapenem-resistant is detected, the isolate can be tested for the presence of a carbapenmase at the public health lab. And this is actually coordinated through the Antibiotic Resistance Laboratory Network, which I'll talk about in a second. So once a case is confirmed, healthcare facilities and health departments may coordinate it to conduct lab lookbacks in the facility to investigate whether similar organisms with similar resistance profiles have been previously identified and should be tested for the presence of a carbapenmase. And I can't tell you how many times we've actually seen this where a hospital is in one state or one region has decided to submit isolates. They find that there are carbapenmase producers. They actually do a lab look back, find that there were isolates or find there was a cluster recently. And actually, in some cases, those might be tested and they can actually see that there is an outbreak. So it is useful, it has been useful to do these lab look backs when one has been detected. So the Antibiotic Resistance Laboratory Network is a tiered network that was established back in 2016, really to support nationwide lab capacity to detect antibiotic resistance in healthcare, food, and community. And as a whole, the network tracks changes in resistance and helps identify and respond to outbreaks faster. The AR Lab Network includes public health laboratories in 50 states, 6 cities, and Puerto Rico. And labs can conduct carbapenemase testing for CRE and CR pseudomonas at no extra charge to facilities. Positive results are communicated with the health department to help facilitate an appropriate response. So some isolates are actually referred to 7 regional labs, and they assist with more expensive testing. So such as Canada auris confirmatory testing, if facilities and the health department decide to do colonization screening, or if there's targeted surveillance for certain resistance genes such as MCR. And that's also used for targeted surveillance for carbapenem-resistant Acinetobacter testing. And also many of the regional labs actually do whole genome sequencing, which has been useful in many of the outbreaks. So next, once a case is identified, the next step is infection control and assessment. So the infection control assessment tools have been developed by CDC to assist health departments and facilities in assessing infection prevention practices and really guide quality improvement. And they can be used by healthcare facilities to conduct internal quality improvements. And we have specific tools on the website that are available for acute care hospitals, long-term acute care hospitals, outpatient settings, and hemodialysis facilities. Within the infection control assessment tools, there's actually a dedicated section that focuses on detection, prevention, and response to healthcare-associated infections and multi-drug resistant organisms. So there's been over 4,000, probably more, actually target assessments that have been performed. And about half of these have been done in long-term care, a quarter in acute care, and about 30% in outpatient or dialysis. And I think it's important to really highlight that when we do these infection control assessments, a lot of it goes back to basics, which we all know is hand hygiene, personal protective equipment and precautions, and environmental cleaning and disinfection. But I think, going through this, we've actually found gaps, especially with environmental cleaning and disinfection, especially with shared equipment. We found that sometimes it's not clear who should be cleaning what, and it's actually helped further streamline these processes and things that may be overlooked unless you're actually carefully looking for it. So in a number of cases, I think it's helped find gaps in these or places where there can be improvement, even though people think that everyone's doing hand hygiene or everyone's doing PPE correctly. So the next step is colonization screening. The screening of healthcare contacts, such as roommates or others with links, may be indicated for nearly all of CRE, regardless of the tier, and it really depends. The wider point prevalence surveys of units may be indicated depending on the tier and the resources available at the facility. And sometimes consecutive point prevalence surveys may need to be done over weeks or months if transmission is detected within a healthcare facility. And this really varies on the type of outbreak, the resources available, the type of bug, and the tier. So each case may be a little bit different. Screening can be performed at the AR labs at the regional laboratories and CDC, and this includes swabs, shifting, and testing are all provided free of charge. At this point, rectal swabs are the most commonly used for detection, and I'll talk about in a little bit for a number of reasons. And it's usually most commonly used for CRE and CRPA, especially the 5 carbapenamases. So the next step is a coordinated response between facilities. And we know that transmission in one facility in the region has the potential to affect many facilities and patients in the region. I think we're learning more and more about this. As we're seeing more cases that are more of a regional response as opposed to just single facilities. And this figure illustrates some of the work that DHQP has done to quantify patient movement in a region. And I think one of the things that's really pointing out is just how much overlap there is among facilities. So coordinated response between the facilities really depends on how frequently facilities share patients, and they may actually involve admission screening at certain facilities. So the health department often helps to coordinate with these activities to track patient movement. So in order to help facilitate patient transfer and communication, I know you were talking about the standardized discharge forms that we've encouraged to help with clear communication regarding status among facilities. And some facilities and some of the states that we work at may choose to do admission screening if there's a particular long-term care facility or another acute care hospital where they've seen a lot of cases. So it's been a little bit different depending on the facility and the type of organ and the type of screening that can be done. And in some cases, it may dictate if there's an outbreak in one facility, it may dictate how other facilities that share patients may approach screening.
Okay, I want to take just a quick little break and get to some of the questions that have been coming in through the chat box.
Sure.
So let me get back to those here. So Diane asked, why does Nevada not require NDMs to be reported to the state? And Cece, I think you wrote a response. Could you say that to everyone? Let me find you. Uh-oh, did we lose Cece? I think we might have lost Cece.
Hello? How can you hear me?
Yeah, go ahead. Or it was Kamisha.
Can you guys hear me?
Yeah.
Oh, okay. I was unmuting the computer and my phone. So in the explanation that I provided, regulations did pass as much as some of you may know that CRE is a reportable condition in Nevada. I'm meeting with our administrator, Julia Peak, on Friday to work on the timeline for implementing this regulation. So essentially with this regulation, if you have a patient that is positive for CRE, if you have the capability to do the further testing for carbapenamase, that can be conducted at your facility. That will be the next step for us. Number one, making sure that the patient is under the proper isolation and proper measures are being taken to contain, even if it's a colonization, contain that organism to that patient. Then we would want to conduct further testing to see if it is a carbapenamase producer or not, which would elicit a deeper investigation if they are a CPCRE patient. So I know the Valley Health System has the capability of testing for the carbapenamase producers. If you don't have that capability at your facility, the isolates can be sent to the state lab and they'll do the testing for you, which some of you guys have experience with working with us. We provide the swabs for you, and there is a number for FedEx that we have for the free shipping, so it's no cost to your facility to have that shipped to our state lab for testing. They usually get the results back to us pretty quickly. We usually see between 24 to maybe 48 hours at the most. So we are working on that. That is reportable. We just have to work on the implementation part of this regulation. We are still receiving the voluntary reporting from facilities. So I put the fax number, which I believe Ashley stated, our fax number, and our email if you would like to send those voluntary reports in, but the mandatory reporting is coming.
Okay, thank you. And then another question about some mandating in Nevada. So does Nevada plan to mandate CRE screening at LTACs and acute care facilities?
Right now, it's just mandatory reporting, not mandatory screening of all of your patients. But if you have patients, and Dr. Epstein, you can correct me if this is incorrect, if you have patients that have had treatment out of the country within the last 6 months, an inpatient admission, those are patients that we would recommend to get screening because those are usually the patients that you would see with the NDMs or the OXA-48s. We are seeing now patients that do not have any out-of-country travel that are popping up with these organisms. So that's not always the case. But I know with the guidance that we receive for them, those are patients that you will want to have. If you receive those patients in your facility, you will want to keep them in a private room and have them tested to make sure they don't have these organisms before putting them in a shared room.
I just want to, can I just add to that? Can you hear me?
Yep.
So
Yes.
that's a good point. So if a patient has had inpatient healthcare and outside of the US, we do recommend that they get admission screening to test for carbapenamase. Now, I just want to point out that, as you said, we are seeing a lot more domestic transmission, especially with NDM. Initially, I think in the past, we really thought that this was more associated with international healthcare. But really, we've seen a lot of domestic transmission in the US. So the other thing to consider is we've actually seen outbreaks with medical tourism. So I just want you to think in the back of your head that if someone also, even, you know, if they got any kind of medical care outside of the US, potentially, not, you know, for some sort of elective procedure, that's also inpatient healthcare outside the US. So think about screening those patients as well. I think people don't necessarily associate that with international healthcare exposure, but we have seen and outbreaks associated with medical tourism of carbapenamase producing organisms.
Dr. Epstein, why are the recommendations from the CDC on removing isolation from CRE patients so vague?
That's a good question. I think it's vague because we're still learning that. We're still learning about it. I mean, I think, you know, we know that patients can be colonized for a long time with some of these carbapenamase producing organisms. And, you know, I think it's unclear how long patients can be colonized with it. So that's why at this point it's vague, and we give the number usually of 6 months to patients. But we are still learning more about it and trying to understand how long these patients can be colonized with these organisms.
So is it 3 clear cultures in 6 months? Is that kind of the outline?
We do. We have some, I can send, we have like a little blurb about it. I think we usually say 2 6 months and they should be off antibiotics. But some of these high risk patients that may potentially have, you know, be in long-term care facilities for a long time or have indwelling medical devices, they can be colonized for a very long time. So we have some kind of language that we use about it that I can share with the health department to share with everyone.
One question for Kamisha. Did you say that this isolating the patients does transfer to the nursing homes?
For if they have the out-of-country travel. Hello?
No, I was saying if we got a positive CRE, yes, if we got a positive CRE and we're discharging a patient to the nursing home, we know it's a carbapenem producing CRE patient. Is that patient going to be isolated in the nursing home? Is it mandated?
So this is Lauren Epstein from CC. So there's actually new guidance about that. It's the enhanced barrier precautions, which I'll talk about in a little bit. There's actually going to be a COCA call about it on October 24th, kind of going in depth. But there's new guidance, and I'll talk about it a little bit in a few minutes in my talk, but there's a lot of information on the CDC website. It's basically if patients are colonized with multi-drug resistant organisms and they don't have you know, wounds that can't be covered or they don't have diarrhea, then the idea is that these patients don't have to be necessarily in contact precautions, but you should use a gown and glove when you're doing high risk activities, which are, you know, having close contact with the patient, bathing the patient. Anytime you can have exposure to bodily fluids, then healthcare workers should be using gown and gloves. Sorry, I didn't mean to jump in. I don't know if there was more to that question.
I was going to use the same guidance. I know from the CRE toolkit, that's kind of the guidance that it gave for the skilled nursing facilities. You know, it's kind of a case-by-case basis on if they need to be in that isolation or not.
Okay, couple other questions that have come in, and then we'll get back to the presentation. So what is the definition of an outbreak? If a screening shows someone has the CRE organism but is not symptomatic, is it considered an outbreak?
So an outbreak is considered when you have cases of a type of organism or any kind of infection transmission that is higher than what you would usually expect. So in these situations, we're trying to do systematic surveillance across the U.S., but we're trying to understand if you have a case of NDM, we're considering one case in this situation as an outbreak. So we consider one case of NDM an outbreak. And it may be true for KPC in certain parts of the country, but in other parts it may be more endemic. But certain carbapenamases, if you have one case in them, we're considering those an outbreak. So, and something like NDM, we respond to very aggressively. So we use containment with those and recommend screening around those patients. And what was the other question?
That was it for now. So Zuen did write in some explanation about the difference between the 2017 and 2018 data. So you can go there to see that response and explanation. So we'll keep going with the presentation here, Dr. Epstein.
Okay. So let me see if I can find. Okay. So the last part is the continued assessment and screening. And this is really just, so we'll kind of take a step back. So you've gone through the whole containment, you've identified an organism, you've identified something that's new within a region, you screened around it, and now we talk about continued assessment and screening. So this really depends on the organism tier and the extent of the outbreak. Actually, some healthcare facilities may continue to conduct routine periodic screening on specific units to ensure that transmission has stopped. And some places may actually do screening on units, and they may actually do it in combination with admission screening for certain patients with risk factors for CRE. So like I said, patients that have received healthcare internationally in order to quickly detect importation into a facility. So we've had healthcare facilities that will continue to do maybe point prevalence surveys every so often and combine that with admission screening. And as always, as part of continued assessment and screening, healthcare facilities, I think this has been mentioned a couple times on the call, should do prospective laboratory surveillance. So if there is a carbapenem-resistant organism that's detected, it should be tested for the presence of a carbapenemase and remain vigilant if another case is detected. So I just want to go over a couple additional questions that have kind of come up, I think, throughout the call. So one of the questions is, why is an organism identified on rectal swab and not at other sites such as sputum? So I'm just going to highlight, there's one article that we refer to, and one of the questions is, why do we screen rectal sites as opposed to other sites? And there's not a ton of research about this actually. And that's one of the things that we're trying to understand too, is potentially, are some sites more sensitive than other sites? So this actually was published back in 2013, and this was a study done to determine the anatomic sites of colonization and to assess environmental contamination of KPC producing Enterobacteriaceae, and it was done in Chicago. And it was a cross-sectional survey. They looked at 33 patients in the environment at 6 long-term acute care hospitals. And these are patients that were known to be colonized with KPC-producing Enterobacteriaceae, not just detected on rectal swabs, but basically anywhere. And they were identified through whole facility point prevalence surveys. And they swabbed these patients and collected it from intact skin, tracheotomy sites, oral pharynx, urine, and from the rectum. So 33 patients were enrolled, and the single most sensitive anatomic site was the rectal site. And the culture of the inguinal and rectal sites together detected all positive cultures. And actually, I think what's also important is that contamination in the environment was actually rare, and only 2 sites were contaminated in a room of a patient that was heavily, had a relatively high body burden of KPC Enterobacteriaceae, with about 6 anatomic sites that were positive. So this is just the table showing, you can see in the bottom section of the table, when you combined rectal and inguinal, they were able to detect all of the patients. And so frankly, you know, I think we use rectal sites in most of these cases because it's kind of most convenient to do. And also most of the rapid testing that we do in the labs, they've only been approved, especially for the Cepheid, looking at the 5 carbapenamases, they've really only been approved for the rectal site. So it's the most convenient, it's the quickest. Most of the labs have been approved to use it for the rectal site, but I think that there is, interest in looking at other sites to see, you know, in the future if we could use inguinal and run axilla or use sputum for certain types of organism testing, I think that's a question that we have. But for the time being right now, I think the most common site that we use is the rectal site for different reasons. And then another question that came up is that a patient is found to have an NDM producing organism. So in the course of screening, which happened, I guess it revealed that the patient's roommate had KPC detected, and why is this? And I again want to just point out this slide that I showed. And just across the US, KPC is very common. So like I said, it's within states, it can be heterogeneous, but it's by far and away the most common carbapenamase that we see. So it's not uncommon that you would see if you were screening a facility that for NDM, they actually pick up KPC. The problem with it sometimes is knowing if KPC is there because it's in the region and it's it's found in the region, or if there's actually transmission happening within the facility. I think that's some of the things that we run into, is knowing if there's truly transmission when we find KPC, or if that's just the underlying rate that the region sees of KPC. So I just want to talk quickly about, again, just reinforcing this point. So this was published in the Morbidity Mortality Weekly Report back in April 2018, and this was the experience in the first 9 months of containment. This was also featured as a vital signs as a public health alert, and it's really a report on the first about 200 cases from 2017. I just want to highlight on here that you can see when we looked at all the screening, you can see by far and away we screened KPC, we recovered very not commonly, but it was the most common carbapenmase that was detected, much more common than the other ones. So it's not uncommon when we do screening that a KPC would be detected. And again, this is a little bit more recent data. This is from January 2017 to December of 2018. And you can see this is all of the CRE that was tested across the AR lab network, about 21,000, and about 38% were carbapenmase producing, and the most common, again, by far and away was KPC, which was 87%. So, and the next most common was NDM, which was far less common than KPC. So it's not unusual that when you do a screening that you may pick up a KPC producing organism. So the last thing I'm just going to touch on, I know people have a lot of questions about it, I'm just going to touch on it briefly, is the enhanced barrier precautions. And the reason that these were introduced is that there's a lot of evidence that the current implementation of contact precautions in nursing homes is not adequate for prevention of multi-drug resistant organisms. So this approach is a new approach that falls between standard and contact precautions. And I just encourage you to go to the CDC website. There's a lot of information about it. And again, there's going to be a call on October 24th, a COCA call, out really going in depth about enhanced barrier precautions, because a lot of people have a lot of questions about it. So I probably won't be able to answer all of the questions about it today, so I encourage you to listen on the call and also visit the website. And if questions come up after this call, I'm happy, if you want to email me, I'm happy to help find the answer as well. So again, this is a snapshot of the website, just talking about why there's a need for enhanced barrier precautions in the setting of containment. This is actually also from the website. This is a table just showing, I think it's a good clarification, because a lot of people have questions about when to use contact precautions and when to use enhanced barrier precautions. So contact precautions should be used in all residents infected or colonized with a novel or targeted multi-drug resistant organism, which is defined on the website. And primarily if they have the presence of acute diarrhea, draining wounds, or other sites of secretions or excretions that you cannot cover or contain, or units in a facility where there's ongoing transmission or it's documented or suspected. So this one's a little bit more vague, but if there's suspected ongoing transmission in the unit, then contact precautions should be used. And again, contact precautions should be used with patients for C. diff, sorry, norovirus or scabies. Now, enhanced barrier precautions can be used in patients that may have wounds or indwelling medical devices, or could colonize or infected with MDRO when they don't have wounds that can't be covered, or they don't have diarrhea and there's no ongoing transmission in a facility. So, and really for enhanced barrier precautions, the idea is that gown and gloves should only be used during high contact resident care activities. So dressing, bathing, transferring, providing hygiene, changing linen, changing briefs, or assisting with toileting or device care use. And the other important thing about enhanced barrier precautions is it doesn't require necessarily single rooms or restriction of movement or participation within, or restriction of movement or participation within a facility. So that's the general idea behind enhanced barrier precautions. And again, there's a clinical outreach and communication activity call on October 24th at 2 p.m. And I'll get the information about the link, and I'll be sure to share it with the health department. And that's all I have.
Excellent. Yeah, go ahead, Gerard.
So if you're having a patient in a nursing home where dressing, bathing, showering, transferring, providing hygiene, changing linens, changing brief, assisting with toileting, device care, central line, urinary catheter, feeding tube, trach, wound care, any skin up, what are you not going to use precautions for? Because that's about everything we do.
Well, so I think the big things is that in those patients, so when you have close contact with the patients, you would use those high-risk activities, you'd use it, but those patients aren't necessarily, as long as they don't have, secretions that can't be covered, or they don't have diarrhea, they aren't necessarily restricted to a room, and they aren't necessarily, they aren't necessarily have to be in a single room, and they shouldn't be restricted for movement or participation within a facility. So I think it's a good question. I think it's just highlighting that when you have a lot of close contact with residents, that you should be using a gown and glove when they meet these criteria.
What I'm saying is, how do the staff know? I mean, this is everything they do, and then they use all that, and then the person just rolls. Are we putting like drapes over them if they're in wheelchairs?
I think those are really good questions that could probably be answered at the call on October 24th. I don't have all the answers to those questions, so I know that the long-term care team will have some of those answers. So I'm sorry, I don't know all the nitty-gritty details.
This is Terry. How about visitors and family? That's just as important for them to wear their PPE as everyone they're doing any procedures on the patients.
So your question is for visitors and family, whether they need to wear PPE for when they visit nursing homes?
I'm sorry, I can't hear.
Terry, your question's about visitors having to wear protective equipment when visiting a nursing home?
So is it not recommended that all family and visitors wear PPE on these novel organisms and any other contact precautions?
So we generally don't recommend, we don't necessarily, so the PPE recommendations are really for healthcare workers to prevent the spread from spreading it to other patients. We don't, usually when families or visitors come and visit, we don't necessarily recommend that they wear PPE. We just recommend good hand hygiene and washing, making sure that they're washing their hands.
Question from Dawn Wright. Would enhanced barrier precautions also be appropriate for behavioral health facilities?
So right now, I think that enhanced barrier precautions is primarily targeted for nursing homes. I don't know the answer about the behavioral care facilities, but I think that if those principles apply, if a patient had a rare carbapenamase producing organism and there was close contact, then I would think that those would apply in a behavioral health facility. We've seen outbreaks and transmission in group home settings. So if there's a patient that had a rare carbapenamase producing organism and they were worried about transmission, enhanced barrier precautions would probably, if it was able to be done, it would make sense. But I don't know that we have official recommendations about that.
All right, we've got about 10 minutes left, so feel free to keep writing in those questions or unmute yourselves. If you're joined by phone, it'll be *6, or if you're joined through Zoom, it's the little microphone icon in the lower left corner of the window.
I have a question. Somebody actually wrote that VA facilities have been using enhanced barrier precautions in our long-term care for a year. I don't know who said that. Maybe they can talk about their experience using enhanced barrier precautions.
Oh, sorry. Yeah, go ahead.
Hi, this is Beth in the Reno VA, and this has been part of our MDRO
program from central office for actually years, I meant to say, not just a year. And we have little special signs so that if they come in contact with, it's basically exactly what you just said, that if we come in contact, we're going to do care on the patient. They have to wear PPE when they're doing that. If they're going in just to chit chat, they just do hand hygiene. If the family members are just coming in to visit, they don't need to wear PPE, but if they're going to actually do care on the patient, they have to wear PPE. So it's pretty much exactly what you were just talking about. We've just been practicing it for many, many years in our CLCs in the VA system.
And do you do it for patients regardless of what type of MDRO? If the recommendation for enhanced barrier precautions is actually it's for patients that are colonized or potentially infected with an MDRO that or as patients that have invasive medical devices. Do you do it for both, or is it mainly just for patients with MDROs?
It's primarily for patients with MDROs because the VA system does screening. So we identify, but or they have history cultures of.
Okay.
So if they have a history of MRSA or something within the past year, they are put in enhanced barrier precautions until they're screened out. And anybody with invasive lines and things, we don't do an enhanced barrier precautions unless they have an MDRO of some type.
Okay.
And we just practice standard precautions on those patients.
Okay, thanks so much.
Yeah, thanks, Beth. Question, what is the CDC's position on intrafacility communication about these cases to lower levels of care or in returning them to acute care?
So we think that we really encourage communication. I know this sounds cliche, but really encourage communications. We think that there are states, I know you're talking about it, that have these standardized forms that are used. And we think as much as that can be used, that can be helpful. We don't think that necessarily because somebody is colonized with an MDRO, if they're stable, that should inhibit them from moving from a higher care to lower care. So if they need to be transferred, but they're colonized with an MDRO, they should still be transferred. That shouldn't prohibit them from being transferred. But we do encourage communication and just making sure that information is conveyed from facility to facility. We know that this is hard. This is not an easy thing, and it's been a challenge everywhere.
All right. Any other questions or comments out there from the group today? Okay, before we go, I do want to remind you that you can claim CME or CEU credit for participating. So I'll send the link out for that evaluation right now through the chat box. And then I want to do a quick little plug for our antibiotic stewardship echo clinics that meet regularly. So I'll pull up the website here really quick. So these are our antibiotic stewardship echoes where we have infectious disease specialist, Dr. Charlie Krasner, and 2 ID pharmacists, Jessica Thompson and Mike Stander. And these are on the 3rd Thursdays of the month from 12:15 to 1. So it's the same format on Zoom like we used today. And they're just an opportunity for you to come and speak with Dr. Krasner and the team about the issues that you're having in your facility, any specific patients that you're particularly concerned about, and consult with them about some things that you can be doing to help your facility and help any specific patients that you have concerns about. So you can see our next one is coming up on Thursday, October 17th. And like I mentioned, it's the same Zoom information. And if you have any questions, you can always email us at projectecho@med.unr.edu, and we'd love to have all of you from this group today join us for those. So it does look like we've had a couple other questions come in that I want to get to. So can you address CRE with different carbapenamases associated with the same OB?
You mean the same?
Ashley, could you explain that a little bit more? Go ahead, I took you off mute.
Okay, Thanks. I was just wondering if Dr. Epstein could address when there are CRE with different carbapenemases, so NDM, KPC, that sort of thing, that are associated with the same outbreak, how it is that the different carbapenemases can be associated with one outbreak.
So, like I said, when we find that there's transmission within a facility, so it may be that the MDM is rare, is actually the outbreak, and you may also see KPCs too. But all of this may be just highlighting the fact that there needs to be better infection control, better hand hygiene, and just basically showing if you're having transmission of two different carbapenamases, that may be possible, but it may actually be that this is just highlighting the fact that there may be issues within the facility that need to be addressed in terms of environmental cleaning, hand hygiene, and just other aspects of the outbreak, because it all basically comes back to infection control. So it's possible that you can have an outbreak and really you're finding two different organisms, but it may be actually that it may be an outbreak of NDM, but you're just finding that potentially you're also finding KPCs that are the baseline rate of KPCs that you could potentially see in a region. And sometimes it's hard to tease out one from the other. I don't know how well that answered the question, but sometimes it's not clear, and sometimes it may just take a little digging to figure out which one is actually causing the outbreak, and what kind of screening you need to do, what kind of surveillance needs to be done, and basically just really assessing and then doing a good infection control assessment.
One last question, Dr. Epstein, about using the chlorhexidrine wipes. Have you been acquainted with Dr. McKinnon in California and his studies of nursing homes and long-term acute care with CRE and using enhanced CHG use?
No, I think I've seen those. You're not talking about the SHIELD, the study, and
exactly, that's what I was talking about.
Just using, you mean in terms of the rates of CRE that they found?
Yeah, they were starting to bathe like the entire, when they get an outbreak, they just bathe the entire facility with CHG, and they were seeing that it was squelching the outbreak. And I just was wondering if the CDC was going to do more of those kind of studies on implementing stopgap measures on if you do have an outbreak. What should be the exact implementation to help stop it, and are we going to give that kind of direction instead of just like kind of vague toolkits, a little more toolkits on, you got an outbreak, do this, and that would really help in all levels.
I think that's what we're trying to do. I think we just haven't, I think every place is different. I think one of the challenges that we have now, like I said, is it's not just in one facility when we find an outbreak. It's a lot of times it's in an entire region. So I think trying to figure out how we, kind of the next step of containment is not that a lot of times when we find these places, it's not just a problem in one facility, it's actually a problem in 3 facilities, or they're having a lot of transfers. So by the time we find it, we've actually seen it in a couple of different places. So I think we're just, trying to work through that and figure out the best strategy for doing that. And it really, I think, depends on the region. Like I said, the type of organism, how you respond to an Acinetobacter outbreak is a little bit different than potentially, how you respond to an NDM, and really depends on the tier of the organism and how aggressive it is. So I think there's a lot of, it's a challenge, and I wish that we had kind of a magic bullet, but I think at this point we don't. I think that's why we're, it's really kind of a number of steps in containment. It's not just like one thing that we can do to stop it.
All right. So yeah, we're just about out of time. There was a question about when more information on that COCA call is going to be going out. So you listed the date and time here. So yeah, how are folks going to find out some more about that?
I will send a link to you guys as soon as I have it. And then if you could share that out, that'll be great. I will make sure to do that. I'm just waiting for them, the long-term care team, to send me the link.
Definitely. Okay. All right. Well, thank you so much, Dr. Epstein. Thank you, Ashley and Cece. This was a great session today. Thanks for the questions, everyone. And yeah, we hope to see you back for our other antibiotic stewardship echo clinics. Again, third Thursday of the month, 12:15 to 1 p.m. And have a great rest of your day. Thanks, everyone.
Thanks.